Good morning, afternoon, or evening, everyone, depending on the part of the world you're in. Thank you for joining us in our EmPowHER webinar on cosmetic phlebology. I'm really excited. We've got lots of really fantastic presentations and panelists today. But before presenting everyone, we'll go ahead and have our introductory videos from Vein and Lymphatic University. If we could have that, please. Technical team, can we have the introductory video from Dr. Kaczorowska? Thank you.
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kabnick, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled EmPowHER, which was developed by Ruth Bush, Sarah Oneida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
I am muted. Thank you, technical team. So next what we'll do is I'll just share a couple of introductory slides. So first of all, we just wanted to thank our supporters from Boston Scientific and Medtronic for their support of the EmPowHER webinar series. So today we're talking about cosmetic phlebology, and as you can see, we've got a number of excellent presenters. Dr. Bush and I will be moderating as usual, and if you have any questions to ask, please put them in the chat and we'll keep an eye out so we can discuss them live. And this is what we'll be discussing today. So we've got a number of different presentations relating to cosmetic phlebology with some of our expert colleagues. And we also have Dr. Florinda Velletas, who will be joining us as a panelist. And all of these are experts in venous disease and the treatment of varicose veins and telangiectasia. So we have quite a busy schedule in terms of the presentations, so I'll stop sharing my screen. And if we can start off with the first presentation, please, technical team, so we can maximize time for discussion later. Thank you.
Ladies and gentlemen, first of all, I would like to thank the organizers for the opportunity to contribute to this event. My name is Aleksandra Jaworucka-Kaczorowska and I am from Poland. I will talk about the progress in treatment of C1 disease. I don't have any conflict of interest to disclose. At the beginning of my presentation, I would like to emphasize that for patients with reticular veins or telangiectasias or varicose veins with mainly cosmetic concerns, intervention is not mandated. Before I establish the treatment strategy for C1 patients, I would like to clarify with how big problem we are dealing with. According to Edinburgh Vein Cross-Sectional Population Study, 90% of subjects were classified as having telangiectasia. Advancing grade of telangiectasia were associated with statistically significant trend for increasing incompetence in superficial veins or either superficial or deep veins. There was a significant linear trend in grade of telangiectasia and degree of severity of trunk varicose veins. Among subjects with no telangiectasia, 85% of them had no trunk varicosities, while this dropped into 51% among subjects with advanced telangiectasia. Only 2 subjects with advanced trunk varicose veins were free of telangiectasia. Based on these findings, the new ASVS 2022 guidelines on management of chronic venous disease of lower limb, which I had the pleasure to be in writing committee, recommend that for patients presenting with reticular veins or telangiectasia, duplex ultrasound of lower extremity veins should be performed before treatment to look for associated incompetent veins. Class of recommendation 1, level C. To confirm that recommendation, I would like to show you some photos of my patient. That lady came to me because of the diffuse telangiectasia. There were no visible varicose veins, only a small tiny varicose vein on calf. Although there were no visible signs of truncal incompetency, during duplex ultrasound I found incompetent great saphenous vein and related tributaries. I performed endovenous laser ablation of the truncal vein and ultrasound-guided foam sclerotherapy of tributaries and sclerotherapy of C1 changes during the second treatment using polydocanol, foam or liquid. And here you can see the results of such treatment after 6 months. Another patient came to me because of telangiectasia on foot without any significant changes on thigh or on calf. Duplex ultrasound has shown the small saphenous vein incompetency and incompetent tributaries on foot. I performed endovenous laser ablation of the small saphenous vein and ultrasound-guided foam sclerotherapy of the distal part of the small saphenous vein and tributaries during the first session. And during the second session, the sclerotherapy of reticular veins and telangiectasias, and the results of such treatment you can see at the photo. Another patient wanted to treatment of reticular veins and telangiectasias mostly on calf and foot, but as you can see, she had also visible varicose veins on thigh. She was after high ligation and stripping and had a stump of 4 cm long and 21 cm wide varicose veins cluster on medial and the lateral thigh and calf and incompetent residual grade saphenous vein. Of course, I started the treatment from the most proximal incompetent vein, so great saphenous vein stump, and I performed endovenous laser ablation, followed by ultrasound-guided foam sclerotherapy of the residual grade saphenous vein and tributaries using 1% STS foam or 0.5% STS foam. During the second session, I started to treat reticular veins and telangiectasias with 0.5 STS foam or liquid, which I diluted to 0.33%. The choice of the foam and liquid depends on the vein caliber. And the results a year after 4 sclerotherapy sessions presents as follows. Foot vein treatment, which was her main concern, was also very good, and the lady was very satisfied with the effect of such treatment. To show you is the lady with diffuse C1 changes with small visible varicose veins on knee. But when you look closer, you can see that there were some veins coming from the inguinal region. And during the duplex ultrasound, I found the inguinal pelvic escape points related with ovarian vein incompetency. And in that case, I performed ultrasound-guided foam sclerotherapy of the pelvic escape points and related varicosities, reticular veins, and telangiectasia. And the results after 4 sessions you can see at the photo. So as you can see, in all cases of C1 patients, duplex ultrasonography is mandatory and significant associated incompetent veins should be treated first before considering the treatment of smaller veins. There are a few treatment modalities which you can use, but the most common is sclerotherapy. There are also a few sclerosing agents, but the most widely used all over the world are detergents, that is polydocanol and STS. The effectiveness of sclerotherapy in treatment of reticular veins and telangiectasias has been described in the literature. According to a randomized controlled trial by Zhang, patient satisfaction and investigators' assessment was significantly higher with polydocanol than with placebo. For reticular veins and small-size veins, 85.7% of investigators and 90.5% of patients were satisfied or very satisfied with the treatment at a 12-week follow-up. And for telangiectasia, so veins smaller than 1 mm, 88.1% of investigators and 86.5% of patients were satisfied or very satisfied with the treatment. Another RCT has shown that 12 and 26-week treatment success rate for polidocanol were 96 and 95% and were significantly higher than placebo, and similarly for STS. Analyzing the difference in effectiveness of sclerosing agents, Cochrane review found no evidence suggesting superior efficacy or increased patient satisfaction with any of the sclerosants. One randomized control trial was excluded from the Cochrane review because the research focused on both telangiectasias and reticular veins with no separate outcome data by vein size. And this study found greater patient satisfaction after sclerotherapy with polidocanol versus STS and 12 and 26-week follow-up. The recently published randomized control trials found that liquid sclerotherapy with 0.2% polidocanol plus 90% hypertonic glucose was significantly more effective than 75% hypertonic glucose alone in treatment of both reticular veins and telangiectasia. Regarding the use of foam or liquid in treatment of C1 disease, a systematic review found no evidence for superior efficacy one form over another, although visual disturbance seemed to be more common with foam than with liquid. Comparing sclerotherapy with transcutaneous laser, randomized control trial found that very good improvement of more than 70% evaluated by blinded experts, and degree of patient satisfaction was the same for both therapies, but laser was significantly more painful. Another study found also no significant difference in cleaning of veins assessed by patients, although blinded reviewers gave significantly better scores after laser than after sclerotherapy. The last study which I would like to cite is recently published randomized control trial which compare NDIAC laser with sclerotherapy with polidocanol and hypertonic saline. And according to this study, for veins more than 1 millimeter, so reticular veins, there were no significant difference between NDIAC laser and polidocanol. But for veins smaller than 1 millimeter, so telangiectasia, the results were significantly better after laser. Based on these trials, the writing committee of new guideline decided to make a recommendation which sounds that for patients with reticular veins where treatment is planned, sclerotherapy is recommended as a first choice treatment. For patients with telangiectasia, sclerotherapy should be considered class 2A level of evidence A, and transcutaneous laser should be considered, so the same class of recommendation, but the level of evidence is B. This is also my treatment strategy. I usually start such patients with sclerotherapy, firstly foam, then liquid, and at the end I use NDIAC laser. And the results after such treatment, after 4 sclerotherapy sessions, are very good, as you can see at the photo. Similar treatment for the second leg. So for reticular veins, I use sclerotherapy, and for telangiectasia, sclerotherapy and transcutaneous laser. And here you can see the results. We also have to remember about the hybrid techniques. Based on randomized control trial by Moreno Moraga, NDIAC laser after foam sclerotherapy with polidocanol has proven to be significantly more effective than sclerotherapy alone at 3 months, 2 and 3 year follow-up. This treatment was more painful, but no withdrawals occurred as a result of pain. The randomized control trial has shown that indocyanine green injected before diode laser is superior to laser alone. A new option with promising results is cryolaser and cryosclerotherapy guided by augmented reality. The results are promising, although more studies are required for validation of this technique. Thank you for your attention.
Excellent. Well, next we'll have the live presentation from Dr. Rodriguez, and thank you, Dr. Jaworucka, for a really insightful and interesting presentation So technical team will let Dr. Rodriguez present live next, and then we'll go back to our pre-recorded presentations and the questions at the end, as we said. Anelise, if you'd like to screen share and present, thank you.
Okay, thank you. Thank you, everybody. So just my screen now. I'll be talking now about the CLACS technique for reticular and spider veins. I'm Anelise Rodriguez. I'm a vascular surgeon in Brazil. Thank you for the invitation, and thanks for the changes in the schedule. So CLACS is actually the cryolaser and cryosclerotherapy. It's an acronym. And it's a technique used to treat the reticular and the spider veins that Dr. Aleksandra has just mentioned there. It's not yet well known, but I think it's going. So I have no disclosures. Patients that come to us, they come looking for solution. They have no complications, that causes no pain. They have no downtime, provides fast return to their activities, and also provides us with immediate and awesome results, things that we know are not possible to achieve. The techniques we use nowadays is still the sclerotherapy, lipid and foam, the transdermal laser, and also the phlebectomies that have already been pointed out by the previous speaker. So sclerotherapy is still the gold standard, even if in foam or in liquid form, and the most widely used medical procedure for telangiectasis, and it's already proven to be very safe and effective in expert hands. The main limitation for it, especially for people with very, very large lesions, is the limit for volume of foam or liquid to use in these patients. The complications most are pigmentation and matting, and anaphylaxis is very rare, but we have to take it in consideration also. In Brazil, we use mostly glucose, dextrose 75%, that is an osmotic sclerosant. We don't see it actually in many other countries, but it's well known in Brazil. Transdermal laser, it's proven to be effective too, but to be used as single therapy, it used to give scars, skin burns, skin ulceration, not to mention the pain that patients complain about. Phlebectomy is effective, has good aesthetical results, but also you have to remember that it's a surgical procedure anyways. It has anesthesia, it has these incisions that prevent people from exposing their legs. In Brazil, there's such a drawback because people are always with their legs out, and there's lots of recovery time required depending on where you are. So the CLACS protocol was installed in the MIAC technique in Clinica MIAC in 1999, and combines the NDE lung pulse laser with dextrose 75% with the use of augmented reality and also the skin cooling. So it's like a synergy, not only the combination. We do first the evaluation of the patient with a meticulous physical examination with a duplex scan and also augmented reality. We perform duplex scan for all of our patients to avoid any mistreatment of them. Then we classify the patients in a score 9-1. This score was described also by Dr. Miak and collaborators. That is a score to actually take the patients, all the C1 patients from the same box, and differentiate them by if there is or no axial reflux, if there are perforator reflux, and for the size of the veins, so for you to choose better the treatment. So the inclusion criteria for CLACS is the veins are up to 1.5 millimeters, although people already nowadays do it like up to 1.5, sometimes even more. We must have no axial, no pelvic reflux, and no perforated reflux connected to the lesion you're going to treat. Basically, in a score 9-1, it will be from score 2 to 6. The score 8, 7, and 9 are those who have the main reflexes connected. So then we go to photo documentation. We use a semi-professional camera, but we can use the camera you use it too, sometimes even the iPad or iPhone camera. We register each session, not only the first one, and then we make at least 20 shots per session. And it's quite important, this part of it, because as you can see here, there's a significant change in patient satisfaction degree and improvement of the perception after seeing the pre and post-procedure photos. So they come, they say they don't really like it, they say it has improved a bit, and once they see the pre-procedure pictures, they change their mind. The procedure itself we use first the cryo laser, that is skin cooling with a skin cooler device. Then we do the ND-YAG laser. The parameters go from 50 to 70 joule per centimeter square. This is like, they are low parameters actually. And we do 1 or 2 shots every 5 millimeters. This laser will cause the endothelium lesion and the elastic fiber lesion, leading to an edema of the vein and shrinking the diameter of the vein also. Then we go to the second part, and this is the sclerotherapy, also under the skin cooling. This actually lowers the level of pain and also cools the sclerosant. After the injection, we put blood stop or cotton balls and tape to finish the procedure. And we make like a panoramic photo to register the treated areas, because sometimes patients complain about areas that actually have not been treated yet. So it requires no compression bandages. It's okay to expose the next day, maybe or not use the compression stockings, and the improvement goes around 30 to 50% per treatment. This was published in the Charing Cross in 2011. Very lack of complications, no main or systemic complications, just the pigmentation that is sometimes easy to handle, and even though in a very, very low quantity. So it was 140 patients with satisfactory results, and very, very few with no satisfactory results. This is the newest one, actually, the one that Aleksandra was talking before. It was recently published in 2009 and was the white paper for the class. No, so minor complications were the temporary ecchymosis and intravenous coagula. There was really, really few patients. No major events, so no allergic reactions, no skin burns, no matting, no infection, no crusting. For instance, we have no volume limitations, we have no shot limitations, so you can do the laser or do the dextrosis as much as you want to. We perform the sessions with a 1 month interval, and after 2 or 3 sessions, we tend to get at least 70% improvement. These are some before and afters. This is after 2 sessions. This is another one. This is from Dr. Miyake. This is a patient from my own clinic also. This is another one. So we can conclude that it's a safe procedure. It has few complications and good aesthetical outcomes, but it was said before. And apart from the high initial investment, so it's mostly for private practice, it still lacks of literature. Recently, there was this this paper was published. It was a PhD from a Brazilian guy, and he compared CLACS with dextrosis versus CLACS with polyrocanol plus dextrosis, and saw there was no main difference in patients' perception after the procedures. But under augmented reality, the difference favors polydocanol and dextrosis. And this is the one that's going on. Actually, it's a trial that I'm conducting in my clinic, and it has the primary endpoint being the incidence of skin hyperpigmentation after plaques and polydocanol foam sclerotherapy. Because nowadays we see is that everything works out good in the end, in the long term. And for cosmetic patients, the main concern is always if there's going to be any scarring or any staining or hyperpigmentation. So it's about to come, I guess, in the next few months, we will have the preliminary results for this. So Professor Kazu used to say that present is talent, future will give you the evidence. And hopefully there are many studies popping up, not only in Brazil, but in some other places where flux is present. So we might soon have the answers everybody's been asking for so long. So thank you for being and for your attention. Let's stop.
Thank you, Anelise, for that really interesting presentation. Flux obviously isn't sort of very widely used, so that was really interesting and insightful. I think we've got in the chat a question from Dr. Martimbeau. I don't know if Dr. Bush, if you're able to read that out, Dr. Martimbeau, if you want to discuss it live now.
Sure. So thank you. And those were great presentations. Appreciate it, doctors. I'm not sure I understand the question. Why do you do, I don't know what that is, for sclerotherapy?
Yes, I'd like to know, Anelise, congratulations for this great presentation. I know it's hard for you to do it today from Dubai. We appreciate that. Now, I have a question. I'm always wondering, why do you need to do cooling when you inject the dextrose?
It's all for the dextrose. It's most for prevent patient from the pain. I mean, it numbs the skin. I'm using it for the laser, so it lowers the pain level and also prevents the skin to get burned. But for the sclerotherapy, it cools the sclerosant itself, not as much as when you put it in the fridge for the cryosclerotherapy, but it cools it down. And also it lowers the pain. So when you go with the needle in the patient, you feel less it numbs the skin. It's like minus 20 to 60 degrees Celsius. It's really cold.
Great, thank you very much.
You're so welcome.
It's nice seeing you.
So I have one question before we move on for anyone on the panel or the doctors that just spoke. Doing sclerotherapy for veins or laser for veins on the foot, so really below the ankle, do you find that is more painful? Do you have more thrombophlebitis? I always get very worried because of how thin the skin is on that area of the body.
Is it for me? For everybody?
Anyone can answer. Yeah.
Yeah, the question was, yeah, you can tell Anelise. Yeah, the question was, is it more painful at the ankle? Yeah, it's definitely.
Yeah, down on top of the foot. What do you do? Anything special? Do you dilute the detergent?
Yeah, definitely the most painful, I think, is the injection when I'm doing the sclerotherapy. So the most painful is the injection. I think it doesn't matter if you inject the fluid if it's diluted, but I usually at the ankle, I usually dilute polydocanol to 0.33 to do not have the hyperpigmentation, especially that they're very superficial and the skin is really tiny. So it's much better, and the results are much better when you do the
Got it. Okay, thank you.
But I think that the most important is the injection.
Anelise, any further comments on that, or just I know you both have to go, so.
I don't know. I've gone through it myself, so I can say it's really much more painful. You have the all the terminations and everything in the foot, it's way more painful, but sometimes it has to be done. I avoid doing like foaming or like high volume, but it's just because of the anatomy stuff. So I sometimes tend to use laser or even do microphlebectomy instead of just injecting it.
Yeah, but the truth is that usually patients really want to get rid of this telangiectasias and reticularness and even varicosities, so they really stay still, and really the results are really wonderful. So I think it's really worth trying.
Yes, it's like they say it's the pain of the beauty coming in. That's it.
No pain, no gain.
I think that when you do injection on the foot, because there's no valves below the malleolus, and the circulation is done differently. So normally it doesn't take many injections, and it normally diffuses very fast. So you have to keep your volume very low. And you normally do not do anything else than only the telangiectasia. And if you treated, like Aleksandra said, the underlying condition properly, normally the vein on the foot will become red after you eradicate all the underlying reflux, which doesn't require a large volume, and it diffuses. So you have to be very careful. So normally 1 or 2 injections in patient. You have to warn the patient that it will be painful, but they, like Anelise said, they want it, they'll take it.
Yeah, and the most important thing is to not treat all these veins in one round. So you should start from the bigger veins and then wait, and after a month you will see that the smaller veins will disappear, and then when you see the veins which did not disappear, you can treat them. And then, of course, the amount is very important, not to put through one injection a huge amount. They usually start with the foam, even on the foot, and I inject the bigger veins, varicose veins or reticular veins, and then after a month, I do sclerotherapy with the liquid, and the results are
one question I have for Aleksandra. I want to know, elderly patients, when you see the venous pearls, you know, these little round purple veins on the foot, do you inject only the pearls, or do you really put the patient through the treatment of underlying conditions if they have large veins? I'm talking about patients over 85 years old.
You know, I always treat underlying conditions, even if patients is, yes. You know, my oldest patient is 93, and she had a real varicose vein. So I did a laser first, and then a sclerotherapy of related varicosities. And she had also varicose veins and telangiectasias and corona fabricatica. And I treated her, and it was really amazing. So I think you shouldn't think that over 85 or if over 75 are patients we shouldn't treat. Sclerotherapy is, I think, the best method of treatment of such patients. You know, there's no risk of treating such patients. I think it's definitely the best way of doing it. So I always
patient will come because they had hemorrhage. So normally what I do is these patients, they have these little tiny purple round, very small round vein. They're not linear. There's only little spots. And I will inject only the spots so they will not bleed anymore. It's very important to do that. And then putting them at 90 years old, putting them through, you know, a whole session of treatment could be harmful. And then for me, a good practice is to close only these little tiny pearls. We call them venous pearls.
Don't you think that if you do not treat the underlying...
No, you don't have to. They will close, but they're the ones who bleed.
After, yes, of course, it will close for a month, 2 or 3, 4, half of the year. But then, because the pressure, the venous pressure is higher, it may appear once more. So I think that the most important thing is always to treat an underlying pathology, and it is also recommended by European guidelines, the new one which we just published. So we do not start from treating the small veins. We always start from the underlying pathology.
These patients do have comorbidities, and then you have to be very careful.
Yeah,
you want to treat the urgent matter, and
yes,
then, like I say, doing this, it lasts more than a month. Believe me, it does last more than a month. You want to avoid that one of these little telangiectasia will burst.
Yeah, I can agree with you that if you have a patient with a bleeding, you can treat, and in that moment, the things which is bleeding, you are doing this as emergency procedure. But then, of course, you can have them on the compression all the time. But if they don't want to have the compression therapy, I think the underlying procedure treatment should be done. Yeah.
Thank you.
And can you tell me what do you think? What comorbidity you should be stop you for treating such patients? What comorbidity? What other diseases which the patient can have in this age that will stop you for doing this procedure?
Well, they're diabetic. They have high blood pressure. I mean, some do have cardiac
but there is no
problem. So anyway, it's just putting patient through many sessions and large volume of foam. And a lot of times, especially in Canada, the treatment is not covered by any insurance. So a lot of times those patients don't have, the resources. Yeah. And then they normally come with the daughter, that would bring them. They're not mobile. I mean, they don't ambulate properly. They cannot wear any compression stockings. So I'm talking about the elderly that really are limited in their mobility.
So if I can interject, both in the interest of time, actually, because this is a really interesting conversation, but also just very quickly from a UK perspective, where I have had, this is very interesting to me because I've had zero experience of cosmetic phlebology, because in our training, we just don't do it. It's all sort of National Health Service. I guess you're both right in a way, it really depends what the patient wants initially anyway. And of course, if you've got hard signs like, they're bleeding, then you have to do something. But if you've got someone who's, quite unwell, very frail, is at high risk of potential complications, VT, whatever, then you might consider perhaps limiting what you do. But absolutely, if someone's more straightforward and a little bit fitter and wants to have things done, then, absolutely, you would want to treat as much as you possibly could. So I guess you're both right, sort of from our perspective, when we have sort of 90-year-olds that come into our local anesthetic varicose vein unit, we will treat them, we'll treat the whole thing. But if they're very frail and they've got high risk, we might do as little as we possibly can just to get them over whatever they need, to address, like the bleeding or like the ulcer, that sort of thing. So thank you for your.
We're both saying the same thing.
Exactly. I think you're exactly saying the same thing. But this is really great to have your expertise in this. And I'm really sorry, in the interest of time, I think we're going to have to move on to the next presentation. Otherwise, we won't have enough.
And hugs from Dubai. It's really great.
Fantastic. Have a lovely time. Thank you so much for joining, both here and Anelise. Hopefully see you soon.
Yes. Bye, thank you.
Thanks. And if the technical team could move forward with Dr. Martimbeau's presentation, please.
Hello, everyone. I am Pauline Raymond-Martimbeau. Thank you very much for this invitation. And it is an honor and a pleasure for me to discuss today's small vein sclerotherapy. Risk factors are unclear, although prevalence rises with age, hormonotherapy, and during pregnancy. The most common locations for small veins are the lateral aspect of the thigh and leg, popliteal fossa, and upper 1/3 of the calf.
Are you using the video?
Gustavo, if you pause and play again, you might need to play every slide potentially, because it was working fine before. So.
Hello, everyone. I am Pauline Raymond-Martimbeau. Thank you very much for this invitation. And it is an honor and a pleasure for me to discuss today's small vein sclerotherapy.
Do you want me to try to share? Or? I don't know if they're playing PowerPoint or if they're playing the video.
You can share.
Yes, if you can share it, Dr.
Let me see. Well, let me see if I can. I cannot guarantee that either.
I can try as well.
I mean, I wasn't prepared for that, so I'm sorry. I don't know if I'll be able to.
Not at all. Let me see if I can bring it up for you. Just a second. I'll see if I can share my screen and maybe that will work. Let's just try that as a plan B. Right.
Would you like to continue with the following presentation from Dr. Roberts?
Can everybody see this? Yes or no? The presentation?
Yes, we can.
Hello, everyone. I am.
Is it working? Can you hear the audio?
Yes,
working.
Good. So we're going to go with this. Thank you.
Pauline Raymond-Martimbeau. Thank you very much for this invitation. And it is an honor and a pleasure for me to discuss today's small vein sclerotherapy. I have nothing to disclose. Leg small veins are very common in the general population, and it is more prevalent in women. Other than genetic predisposition, risk factors are unclear, although prevalence rises with age, hormonotherapy, and during pregnancy. The most common locations for small veins are the lateral aspect of the thigh and leg, popliteal fossa, and upper 1/3 of the calf. Reticular venulectasia and telangiectasia are complex veins. A thorough examination to find the origin of the reflux is mandatory. The location of the small veins can sometimes give clues about their sources. Treatment depends on their underlying conditions. Recently, B-scan duplex ultrasonography with a high-frequency probe 18 to 20 MHz have allowed practitioners to gain better insight of the underlying reflux points and degree of reflux. It was shown that a certain percentage of small veins connected with underlying venous system or the perforators or saphenous vein. Moraes demonstrated a strong association between trunk varices and telangiectasia. We conducted a double-blind study involving 525 consecutive patients, and all cases involved a diagnosis of small veins, and 884 small veins clusters were studied. There are two different entities of small vein complex. The ones that are fed by saphenous veins, and this is 18.8% of cases, or perforator veins, and this is 8.1% of cases. Those telangiectasia should be classified as C2. And there's the ones that are fed by reticular veins and venulectasia, which are the C1 veins. The C2 telangiectasias, when present, the deeper source needs to be treated first, and the small veins will disappear most of the times without treatment. It is important when you have telangiectasia on the medial aspect of the leg to look to see if there is an incompetent saphenous vein or a perforator vein. And if there is one, then you need to treat that. You can treat the saphenous incompetence by chemical ablation, thermal ablation, laser or radiofrequency, glue, mechanochemical ablation, steam, or surgery. When you have a C1 small vein complex, the telangiectasia can be fed by a single reticular vein or a reticular vein and a venulectasia. Not all visible veins should be injected. Some patients have thin and transparent skin, especially on the anterior aspect of the thigh, where you see a lot of green veins. And if the veins are not associated with clustered telangiectasia, they are the normal reticulum and they should not be injected. The technique is a two-hand technique. The non-dominant hand will fix and angulate the vein, while the dominant hand will perform the injection. The injection should be very precise and of low pressure in order to avoid extravasation. Small volume is the key for avoiding complications. When the telangiectasia are on the lateral aspect of the leg, they are fed by a single reticular vein. And this system is called Albanese system, and it is not due to saphenous incompetence. In this case, we need to treat the reticular vein and treat the venulectasia at the apex of the clustered telangiectasia. On this particular case, where there is a afferent and efferent reticular vein, the reticular vein needs to be treated first, and all the reticular veins that are associated with clustered telangiectasia need to be treated. The telangiectasia will become red after the reflux will be eradicated, and they may disappear by themselves, or you may have to inject them with a low concentration of a liquid sclerosant. You have another nice case here where treating the venulectasia and the apex of the clustered telangiectasia, after 2 visits, the telangiectasia will become red, and then they can disappear by themselves, or you can always inject them with a low concentration of a liquid sclerosant. Have patients stop medicines and remedies that can cause bruising. However, anticoagulation discontinuation is not needed, and testing for right to left shunt and hemophilia is not warranted. Have a health questionnaire, consent form, and take photos. Now let's discuss protocol. If you're going to use liquid for your aesthetic sclerotherapy, of course you need syringe and small needle. There are some syringes with eccentric tip, and sometimes they can be easier to use these syringes for your injection. A new emerging technique called macrofoam, using some spherical uniform bubbles, is also another option, which you need to use a winch infusion set, 27 gauge, 8 inches tubing in order to perform that technique. Microfoam could be used also for small veins, although it is controversial. As long as you use low concentration and you choose the proper vein to inject the microfoam in, it could be also very successful. It is done with a 3-way stopcock or a connector or a vial. And the ratio for the foam, the most popular one, is 1 ml of detergent with 4 ml of air or CO2 or CO2O2. The sclerosants that are available for injection with liquid for small veins are the osmotic solution, dextrose 25% combined with hypertonic saline 10%, or diluted polydocanol 0.2 to 0.5%, diluted sodium tetradecyl sulfate 0.2 to 0.35%, chromated glycerin, sodium salicylate, or a diluted iodine sodium iodine 0.2 to 0.35%. The concentration is normally chosen according to the diameter of the vein. Here you have a video that will demonstrate a technique to inject reticular veins and telangiectasia. The injection is performed with a 26 gauge needle, and it is a needle that has a special elongated bevel, and this is preferred to the 30 gauge needle. While injecting the vein, we create a negative pressure, and this is felt in the palm of the hand, and that's when the injection is performed. There's no injection done under high pressure with that technique. Only the tip of the needle is inserted into the telangiectasia. And very small volume is used. This is an injection of a macrofoam into the reticular vein. Microfoam can be prepared using Tessari technique with the three-way valve, or Martimbeau technique with the vial, or Wong with the CO2 cartridge, French techniques with the female-female connector and a filter. Now, if you're using macrofoam, it's very important that you use a butterfly in order to have individualized uniform spherical bubbles. And the concentration used for macrofoam could go from 0.35 to 1% of detergent. And of course, the volume is very small, so there is no risk to create complication. The bubbles, because they're spherical, you can predict, according to Stock's law, you can predict the behavior of these bubbles, and they break very easily. This case has been treated with one injection of macrofoam. And you can see on the right that the telangiectasia became red after the treatment, and it will disappear now by itself. This table shows the guideline recommendation for aesthetic sclerotherapy developed at the V-Winter International Meeting last year. And it shows that all countries do not agree on a standard protocol for aesthetic sclerotherapy. If there is a failure, one should not increase the volume of the same concentration, but instead reassess the origin of the reflux, look for the highest point of reflux or a deeper vein that is feeding the telangiectasia. Post-care do's: give written instructions with your contact, have the patient watch for signs of allergic reaction, continue normal activities, wear a compression hose 18 to 20 or 20 to 30 millimeter of mercury for 1 or 2 weeks daily, and walk 20 minutes daily. Post-care don'ts: the patient should avoid hot baths, sauna, and strong UV irradiation for a few days. No lifting weight, high impact exercise, or long distance travel if foam is injected. We came up with the acronym Manhattan to describe the complications of sclerotherapy. matting, allergy, necrosis, hyperpigmentation, arterial injury, thromboembolism, technique-related, air embolism, nerve injury. Common side effects of aesthetic sclerotherapy are the post-injection histaminic reactions, the matting, technique-related complication, hyperpigmentation, cutaneous necrosis, and although if it's rare, we cannot forget the intra-arterial injection. Most of the other major complications are very rare. Aesthetic sclerotherapy paradigm. Volume should be small, concentration low, technique adequate, good material, good selection of patients, good selection of injection site, removal of coagulum, and all this should contribute to a great outcome. In conclusion, with aesthetic sclerotherapy performed adequately, one would wish that patients would never resort to tattoo techniques for camouflaging bad outcomes. Safe and effective sclerotherapy requires a conceptual understanding about the process being treated. Technique and knowledge are the key of success of sclerotherapy of small veins, and randomized controlled trials are needed to establish recommendations. Thank you very much for your attention.
Thank you, Dr. Martimbeau, for an excellent presentation. In the interest of time, we're just going to move to the final one. Gustavo, could we please play the final presentation? And if there's a problem, please let me know and I'll try and screen share.
Hello, my name is Dr. Stefania Roberts. I'm a phlebologist based in Melbourne, Australia, and I'm honoured to be part of Cosmetic Phlebology EmPowHER webinar. My topic is cutaneous vascular lasers and indications in cosmetic phlebology. I have no conflict of interest. What I'd like to do is do a brief overview of the differences between the light-based devices available on the market. What is the difference between a laser and an intense pulsed light device, or IPL? I will then focus purely on vascular lasers and the dermatological applications as relevant to us phlebologists. An intense pulse light is a filtered flash lamp device that emits non-coherent polychromatic radiation, so multiple wavelengths between 420 and 1300 nanometers. The ideal indications for an IPL are diffuse telangiectasia, lentiginous, poikiloderma of Savart, and essential progressive telangiectasia. So what is a laser? A laser has a single wavelength, so it is monochromatic. All light waves travel in the same direction and are in phase, so coherent, and they travel in parallel, collimated. Laser light is delivered either via an optical fiber, for example, with endothermal ablation of our saphenous veins, an articulating arm, or in cutaneous phlebological applications via handpiece, like the KTP laser on the bottom left-hand side of your screen. The acronym LASER stands for Light Amplification by Stimulated Emission of Radiation. A basic laser structure consists of a lasing medium, and that determines the wavelength that is emitted. The lasing medium may be solid, for example, our Nd:YAG or 1064 nanometer lasers, the KTP 532 nanometer laser, or the lasing medium may be a liquid or a gas. A lasing medium requires an excitation source. The excitation source may be optical, electrical, a chemical, or another laser. And what the excitation source does is that it is essential for electrons to attain an excited state so that we can obtain stimulated emission. Stimulated emission is not enough to create a laser beam, and hence the addition of mirrors. mirrors reflect photons back into the gain medium to cause further stimulated emission of the electrons. So therefore, we obtain amplification of stimulated emission of electrons, which then leads to a laser beam, which is emitted via the partially reflective mirror, which gives us the device that we have in hand. Laser tissue interactions can be one of four. A laser beam may be scattered, reflected, transmitted, or absorbed. The absorbing molecule is termed a chromophore. And for vascular lesions in phlebology, our chromophore is hemoglobin. When we look at the absorption spectrum for laser wavelengths, we can see that hemoglobin has several absorption peaks between 532 and 595, and then again between 800 and 1064. Now, there are several principles that are essential when utilizing and operating a laser. The first is the theory of selective photothermolysis. This was a concept introduced in 1983 by Anderson and Parrish, and the aim of selective photothermolysis is to provide permanent thermal damage of a targeted structure with the surrounding tissue held intact. Thermal relaxation time is another important concept with lasers, which is the time taken for a target chromophore to lose 50 to 63% of the generated heat to surrounding tissue. Thermal relaxation time is tissue-specific, chromophore-specific, and will vary according to the size of the target. The laser pulse duration is selected to match the thermal relaxation time of the target at hand. Selective photothermolysis requires the knowledge of the target's thermal relaxation time in order to minimize collateral damage and selectively destroy only the intended target. Selective photothermolysis and thermal relaxation time allows lasers to be specific in their treatment and minimize side effects and complications. Now, irrespective of whether we're using a vascular laser or an intense pulse light, both are light-based devices and have similar side effects and complications. The side effects are erythema that may last for 3 to 4 hours to 1 to 2 days, pain during the treatment that may be alleviated by the use of topical anesthetic creams or via a blow-in Zimmer device. Edema may be experienced post-treatment, pruritus, scabbing, or purpura. Complications include hypopigmentation, hyperpigmentation that tends to be transient, or scarring. Now let's look at the vascular lasers. Vascular lasers may be either shorter wavelength lasers, the 532 KTP, or the pulse day laser, which are either 585 or 595 nanometers, or the longer wavelength lasers that are typically 1064 nanometers. Now, the wavelength of the laser determines the depth of penetration. The lower wavelength lasers, the 532, 585, and 595, have a shallower depth of penetration, and the chromophore tends to be red targets, hemoglobin or melanin, and telangiectasias, for example. The longer wavelength lasers, the 1064 nanometer lasers, have a greater depth of penetration and can target larger structures, for example, reticular veins. When using lasers, the treatment parameters are essential and they depend on the lesion location. Is the lesion on the face or off the face? The lesion morphology and the Fitzpatrick classification of the patient at hand. Now let's focus on facial vessels. The most commonly used devices are the pulse dye lasers, the 585 or 595 nanometer lasers, your potassium titanyl phosphate or KTP 532 nanometer lasers, or we can utilize an IPL. The 532 and 1064 nanometer lasers are ideal for tracing discrete facial vessels. It's important to note that perialar vessels can be recalcitrant to laser treatment. Now, blood vessels, their etiology may be from sun damage, rosacea, familial, estrogens, post-traumatic, or KT rubra. Treatments include avascular lasers, diathermy, or sclerotherapy. Here we have a patient with facial telangiectasias. The target is hemoglobin. Here, a KTP 532 nanometer laser was used, and we can see a before and after. Nasal vessels respond quite well on the dorsum with the 532 nanometer laser, but perialar vessels may be recalcitrant to a KTP or a 585, 595 nanometer laser. Here we have a spider nevus immediate results post laser. And this is a 9-year-old patient of mine that presented with her mother with a spider nevus in the left infraorbital area. And we can see that one treatment with a 532 nanometer laser led to complete resolution of the spider nevus. And this is the result at 4 weeks post. Now, vascular lasers are useful, the longer wavelength lasers, your 1064 nanometer laser for periorbital veins. It's quite safe with the use of eye shields, which you can see on the right-hand side. Here we have the patient pre and immediately post 1064 nanometer laser. Another patient, again, with reticular vessels in the infraorbital area. Yes, they can be treated by sclerotherapy, but laser in this area with adequate eye protective gear is very safe and efficacious. Venous lakes, which are ectatic, thin-walled venules in the superficial papillary dermis, respond very well to the 1064 nanometer lasers. If red lesions are found on the lip, they respond to the lower wavelength lasers. A study by Dr. Phil Beckor, a Melbourne dermatologist, was published where 35 patients were treated with the Nd:YAG, and after one treatment, 94% clearance was noted. Port wine stains that are capillary vascular malformations, they're malformed dilated vessels in the skin, they're red or purple in color, they have a well-defined border, always present at birth, and they grow in proportion to the child's growth. They also can be treated with our vascular lower length lasers. Typically, 8 to 10 treatments are required at 6 to 8 weekly intervals, and 80% fading can be expected. And it's important to note that facial lesions respond better compared to port wine stains in the lower extremities. Other lesions that can be treated with vascular lasers include acne, facial flushing, rosacea, Campbell-De Morgan spots anywhere on the body, sebaceous hyperplasia, poikiloderma of Savat on the neck, keratosis pilaris rubra. They can be used for photorejuvenation or leg veins. Now let's move from the face to some example of off-the-face treatments. Here we have reticular vessels on the breast that have responded with the 1064 nanometer laser. Again, another patient post-breast augmentation with dilated reticular vessels and the immediate post-treatment of the right breast showing clearance. Angiokeratomas that are benign capillary ectasias in the superficial dermis, here on the vulva and on the right-hand side on the scrotum, may be treated as well with vascular lasers because the patient may be presenting with bleeding problems from the angiokeratomas or for cosmetic benefit. Can lasers be used for surface leg veins? Yes, they can. And the indications are essential progressive telangiectasia, which are capillary dilatations of unknown origin. And they can be used for telangiectatic matting once the underlying source of the matting has been addressed. Sclerotherapy can be used for matting, laser alone, or a combination of sclerotherapy followed 4 weeks later with a vascular laser treatment. But we all know that for leg veins, the gold standard still remains microsclerotherapy. Now, post-sclerotherapy, we do encounter post-sclerotherapy hyperpigmentation, and we know that the best treatment for hyperpigmentation post-sclerotherapy is chronotherapy or time. But if 12 months have transpired and the patient is still cosmetically concerned about the hyperpigmentation, the use of a 532 KTP laser may be utilized. So vascular lasers play a pivotal role in the treatment of facial vascular lesions. They're safe, effective, and they produce reproducible results. Vascular lasers also have a role in the treatment of lower limb veins and vascular lesions of the face. Thank you for your attention, and I hope you enjoy the remaining webinar.
Right, so we've only got a couple of minutes left for discussions. I just wanted to ask Dr. Vietas actually a question about patient expectations in cosmetic phlebology. So as I said, I missed that interface. So is the counselling different, or I imagine the expectations must be different in patients who come for cosmetic procedures? And are there any specific things or adjuncts that you use, such as using pictures before and after, as we've heard from some of the other presentations? So what are your thoughts on that?
Yeah, well, okay. Hello, first of all, thank you for the invitation. It's an honor for me for being a physician as a woman being this EmPowHER webinar. Well, first of all, yes, we use a lot of photos. It's for us, it's something very important in the clinical history. And it's something that helps us to compare the previous and the after procedure. I have something to say that it's something that we're really taking care of, and it's that we're using the 18 megahertz to the reticular veins, and this helps us a lot just to complete the treatment. So Dr. Raymond, I want to thank you because you helped me a lot to my practice. So yes, we use the pictures, and it's something difficult with patients because when we are treating just telangiectasias, they just want to see the cosmetic results. So the pictures is our great ally.
Sorry, I'm muted. Thank you very much. And, Dr. Martin, anything specific that you wanted to say about counselling this sort of cohort of patients, particularly, I guess, if we're talking about, potential risks and benefits and what the expectations are to have a cosmetic procedure, I guess.
I'm sorry, I was reading.
Oh, no.
The questions. Okay, I'm so sorry.
No, not at all. I was just wondering if you had any comments with respect to counselling patients, particularly in light of what we were saying before about risks and benefits, especially if they're coming in for cosmetic procedures, and if the patient's expectations are different, and how you might address that expectation that the patient might have of maybe getting better or getting the veins to disappear with minimum risk and guarantees, and what patients expect.
Yeah, you touched the point. I think that the most important is that the patient do have good expectation, realistic expectation. The patient needs to be educated before you do the treatment. So the patient know that they will need multiple sessions, and it's impossible to re-educate, treat all telangiectasia in one session. And then you see patients sometimes they'll come and see you and say, I'm coming because, I've got a lot of telangiectasia and I want you to treat them all in one session because I went somewhere else last year and they did everything in one session. Now you wonder why that patient doesn't go back where they went a year prior. And then, so they try to push you, so you'll do as much as possible. The patient has to understand that it is a progressive treatment, that you may have to re-inject sometime at the same area. But I think counseling the patient properly with a nurse that will explain all the different steps will help you in your treatment. So when you come to do your treatment, the patient is aware of the interval between the sessions, the cost, and of course the risks and benefits. If the treatment is performed progressively, and again, whatever we discussed today, that underlying condition, and go from the deepest to the more superficial, anyway, the results or the outcome should be absolutely almost perfect. But if this is not done properly, of course, it could be a disaster. And so I think that one should know one thing is, if the patient goes to see you because they think you're the best. So what I leave you with a message is, make sure that you get proper training before doing small veins. Because yes, the patient would think you're the best, but you have to prove that. And don't try anything. Don't think that small veins is a easy treatment. I think it's much more difficult to do have aesthetic results with small veins than doing large veins. For me, large vein is much easier. Injecting foam in a large vein, I mean, if you do it properly, I mean, there's very less complications. But the small veins, again, if you don't have experience, if you're not skilled, please recognize that and have good training. That's, I think, my leave home message.
I think it's important. It's something we do with our patients. It's telling them we like to have a control once a year. So even when we finish all the procedure and all the steps, 5-4 sessions, it depends on how the telangiectasia is. We tell them that we like to give a follow-up for 1 year, and maybe a lot of years we do it.
Thank you both. I think you're absolutely right. They're really valid points, and actually being able to audit your own practice and being able to check that what you're doing is correct and the patients are having good outcomes is really important. I'm afraid it was slightly over time, actually, and this was a fantastic webinar. I know there are a number of questions in the Q&A that we haven't had time to address. However, we will be, I think, most likely having another cosmetic phlebology session, even looking at sort of some of the other aspects that we haven't touched about. So please keep your questions, and we will ensure we get to them in one of the next webinars, absolutely. And I will make a note as well, just to make sure that we can look at some of these questions later. Thank you both for being here and your contributions. Thank you to all the presenters today who made time, and thank you to Dr. Bush for her support today, and we look forward to seeing you in the next webinar next month, which will be on pelvic venous disease. I think it's the 5th of March, so we look forward to seeing you then. Thank you. Take care.
Thank you so much.
Thank you very much for the to the organizers. That was a great webinar. A lot has been said in 1 hour. Thank you.
Thank you so much. It was a pleasure.